And for people that don't know me, I'm Horacio Walker. I'm the Dean of Woodring College here at the Western Washington University. And for the university, it is important to open up opportunities to talk about these things and have an opportunity to pause, reflect, share with one another what we are experiencing and what we think about it. So, and this is an opportunity also to reach out to the community, to reach out to people that are doing all kinds of things and going through all kinds of challenges at home and at work, in their personal life, in their social life, etc. So with that said, I again welcome everyone who's here, and I pass it on to Devyani.
Hi everyone, I'm Devyani Chandran and I am the director of the WW Palliative Care Institute. Welcome to the Proactive Care Planning in the Time of COVID-19 webinar. We will be exploring a few questions in this webinar. Basically, what is proactive care planning? The role of post in life-sustaining treatment, and we'll be talking a little bit about resources that are available to you just to keep this conversation going and completing documents related to proactive care planning. Our speakers for today, I'd like to introduce and welcome Sharman Figgenshaw. She's a palliative care nurse practitioner who's been working with families facing end-of-life transitions for over 30 years. She co-chairs the Washington POLST Task Force and is now with Honoring Choices Pacific Northwest as POLST and Serious Illness Clinical Skills Program Manager. Our second presenter is Hillary Walker, and she's the Advanced Care Planning Coordinator at Peace Health Medical Group in Bellingham. Walker, has worked really for a very long time to bring awareness to the value of advanced care planning for patients across the Peace Health system. And she's a certified facilitator and instructor with Honoring Choices Pacific Northwest, and is an active member of the Washington End of Life Care Coalition. I'd also like to introduce our moderator for this panel. Marie Eaton is the founding director and currently the community champion for the Palliative Care Institute at Western Washington University. And the Institute is a partnership with many community agencies and volunteers. And Marie has played a really key role in bringing together community conversations on end-of-life planning, palliative care, and I think is continuing to bring these conversations together in the time of COVID-19. So I'd like to now hand over, this particular discussion to Marie, who will be talking a little bit about really the rules of discussion and how we carry this forward. So Marie, it's on to you now.
Okay, thank you, Devyani. I want to, again, welcome you all. There are about 100 people signed up for this webinar, and we're thrilled that this kind of outreach is reaching so many folks during this time. I want to just acknowledge that you will have a chance to ask questions. So there is both a chat function and a Q&A function live on this webinar. So you will have a chance to feed questions in. Most of the questions will probably hold till the end, but there will be plenty of time at the end to respond to whatever questions you have. I also want to say that we're recording this webinar and that this recording will be available eventually on the Palliative Care Institute's digital repository site, and that we have also prepared a list of resources which we will share with all the participants after the webinar is over. So as we begin, I want to, the participants or the presenters wanted to provide a little poll just to find out who we're talking to today. So if you would please respond to this poll just quickly so we can see where you are from. Okay. Okay, so about 60% of you live in Whatcom County. A few from Skagit County, and then others from Washington, and a few of you from farther out. So that's great. That helps us understand who we're talking to today. So thank you so much for that. Okay, so I'm going to turn this over to Devyani, excuse me, to Hillary. to take us into the beginning part of this workshop.
Thank you. I'm going to go ahead and pull up my slides here. Are those sharing well?
Yes.
Okay, very good. Thank you so much for joining us here today. I'm really grateful to be here and want to say that I'm incredibly honored to be on this call with two of my biggest mentors in this work, Charmin Figgenshaw and Marie Eaton, who have been incredible teachers and support for me in this work. So I just want to say thank you to both of you. So we're here to talk about proactive care planning for healthcare wishes, and we'll be doing a general overview of it, what advanced care planning is, what an advanced directive is, why this is important, and then specifically talking about how things have shifted a little bit in time of COVID, or a lot in many situations. So some things that we're going to be talking about today is, again, talking about what advanced care planning is and why it's important, and especially now. Why it's really valuable to reflect on values and personal beliefs when we're talking about advanced care planning and talking about medical care. A big part of what we'll be talking about today is how to select a healthcare agent and what it means to choose a backup person or an alternate agent, and how important this decision is in all of these conversations. Lastly, how to express these wishes into legal documents. And then once the documents are completed, how do we share these documents? Where do we keep these documents so that they can be easily accessible when they're needed? So I'd love to just give an overview of advanced care planning. I think a lot of times it can be confusing about what we're actually talking about. So advanced care planning is just what it sounds like. It's an opportunity to think in advance about the care that we would want if we had a sudden event or illness and we were unable to speak for ourselves. The act of advanced care planning also allows us to choose who we trust to make medical decisions on our behalf if we are unable to make those decisions for ourselves. And the process is a lot about the conversation, and also involves creating a plan, putting that plan in writing, sharing that plan with those who are really invested in our care. And that could be our family, our providers, our local hospital system, and we'll be talking about that as we go along. So I just want to acknowledge that sometimes the focus is narrow when we're talking about advanced care planning. So we will be focusing on how to get this information in writing into documents. But quite often those documents, whether it be an advanced directive or a POLST, which is a physician order for life-sustaining treatment, which we will be talking about both of these documents. But it's really not possible that these documents could cover every scenario. So even though the documents are important and very helpful to have things in writing, you'll be hearing both Charmin and I talking throughout today about how important the conversation is and how these conversations change over time. And I trust that when we're talking about advanced care planning, even though we are talking about specific documents, that starting these conversations and engaging in this work is really getting us thinking about other areas of planning, aging in place, in-home care, supported living options, understanding what palliative care is, what is hospice, things about how we want our body cared for at the time of death, and what is really important to us as it relates to personal beliefs, spiritual beliefs, cultural beliefs, etc. So why is advanced care planning so important? Really, it's important because if we take an active role in having the conversation about what's important to us, then it would make sense that the care we would receive down the road is more in alignment, most in alignment with care that matches our goals and honors our wishes. So there is a study that was created by Respecting Choices out of Wisconsin that speaks to the fact that 82% of people understand that advanced care planning is important. However, 23% of people nationally have actually taken the time to have these conversations and put these conversations in writing. So I know that a lot of people are on the call in Whatcom County. We're in Whatcom County, and if we look at Whatcom County, at least for patients who have been cared for in a PSELF facility, whether it be a hospital or a clinic in the last year, we're at approximately 25% of people have documents on file. So that means 75% of people, we don't have any information in their medical record that can help guide their care. So we have a lot of work to do. And I would also just love to point out that even if somebody has a document on file, we need to dive deeper into whether these documents are actually useful to help guide care and if they provide accurate information, up-to-date information for the person that we're providing this care for. Some other reasons why advanced care planning is really important is that this study also showed that 70% of people, when asked, would choose to spend the end of their life in their own home. However, what we have seen is, again, in this study, 70% of people were, at the time the study was done, were dying in skilled nursing facilities or hospitals. Now those numbers are improving. We are seeing that more people are being able to die in their own home if that's their wish. And we do really believe that a lot of that is about advanced care planning and engaging in these conversations much sooner in somebody's life or along somebody's illness. So another reason why advanced care planning is really important is less time is spent in the hospital when people are engaging in advanced care planning, especially at end of life, and receiving less aggressive and non-beneficial treatment, again, when these conversations are engaged in earlier. So I think we're going to put another poll out there to find out, just get a feel for the folks who are on the call with what is your current relationship with advanced care planning and completing these documents. Where are you currently at in the process? So this poll is, how comfortable are you with advanced care planning on a scale of 1 to 5? 1 being, I'm very uncomfortable talking about my end of life wishes, all the way up to 5, very comfortable. We have a plan and we talk about it often. And there's also 6, none of these choices fits me. So if you can take a moment to complete that poll, that's super helpful. And I don't know, Marie, will the answers pop up on the screen or will
in just a minute?
Okay, perfect, thank you. As Horatio said, we're all learning how to share this information in different platforms. And
can you see it now?
Okay, answers coming in. Most people feel very comfortable and have a plan and talk about it often. Yay! Stars. There are some people, I've thought about it lately, but haven't gotten around to completing a plan. You're not alone there. We hear that a lot. A few people am very uncomfortable talking about end of life wishes. Thank you for your honesty. We'll be talking about how you are definitely not alone in that area either. So that's very, very helpful. Thank you for taking the time to do that. So if advanced care planning is so important and there's data showing that a lot of people really feel like this is important to have these conversations with their families and their providers, why aren't people doing it? And I'm going to share some things that we're aware of and that we've heard of why people are not more engaging in these conversations and completing the documents. But we'd love to hear from you more at the end of our presentation and the question time. So as we saw in that poll, one of the questions was, how comfortable are you with this? And we just want to acknowledge that talking about end of life is not easy. It is uncomfortable for a lot of people. And I just want to say it's not only uncomfortable for patients and families, but it's also uncomfortable for care providers and those of us who are working in clinics and hospitals. When people are a bit more skilled in the conversation, it does make it easier. And there has been a lot of an outpour of information right now, especially in the time of COVID-19, of tools coming out for providers, tools coming out for families, really trying to engage people in these conversations. So that's what it means by skilled facilitated conversations. Do make this easier. If we have a script or we have a guide to give us a place to begin these conversations, it's very helpful not only for patients and their families, but also for those of us who are offering care and offering to have these conversations. We'll be talking about some of those tools a little bit later. Another barrier is that there are, at least in Washington state, there are many different documents that you can choose from. If you've heard me speak before, you've heard me say that when I first came to Whatcom County and I was just learning about the community of advanced care planning here, there were 6 different documents being taught to in different community places. So whether you went to your church for a workshop, you got one document. If you went to the clinic, maybe you got a different document. So it's a big thing that we're aware of and have been working on a lot, at least in Whatcom County and throughout Washington state, to try to simplify what the options are for documents so that people don't feel so overwhelmed. And then on top of the documents you can download online, there are multiple documents created by lawyers, etc. So there are a lot of documents out there and sometimes that can be quite overwhelming. Another barrier is sometimes people do believe that they need a lawyer to complete medical advanced care planning documents. And while lawyers are often helpful in the process, it is not required to have a lawyer to help you complete these documents. Many of these documents are free for download and print online, and there are a growing number of facilitators who can help with the process. So what is an advance directive? This is the legal document that we're talking about. So there's the conversation, there's understanding values, understanding our own medical condition and what our options might be and what those options might look like, and then translating the conversation into a legal document. So the photo that you see here is the front page of the most commonly used document here in Whatcom County. It is a document created by Honoring Choices Pacific Northwest. And so this is the most common document that we're using, but no matter what document you're looking at, and really no matter where you live, all advanced care planning documents have the same essence of information. So one part of the document is often called the durable power of attorney for healthcare. This is where you have the opportunity to name who you trust to be your medical decision maker. This person is sometimes called your healthcare agent, your healthcare proxy, your healthcare surrogate. So you can see just in conversation why this can be confusing for people. It's understanding the language and then moving from there. So the documents sometimes are 2 different parts. The durable power of attorney for healthcare, where you can name your medical decision maker and your alternate agents. And then the second part is the healthcare directive, where you can speak to the kind of care you would or would not want in certain medical scenarios. So again, in the Honoring Choices document, they're 2 separate documents. Sometimes they're made as a combined document, but they have the essence of these 2 pieces. The healthcare directive part is also sometimes called a living will or a directive to physicians. So ideally, an advance directive really should be completed by anyone 18 years of age and older who has decisional capacity. And because we can all face a sudden or unexpected event at any time. So sometimes these are called end-of-life documents, and we're really moving away from that language because they're really life documents. It says that if I have a sudden or unexpected event, whether I can temporarily not make medical decisions for myself or it's more long-term, I want a guide to be available to help guide my care, and so people really understand what's important to me. So choosing the healthcare agent is really the most important part of all of this work, is really thinking deeply about who you trust and who knows you the best. So when choosing a healthcare agent, there are some requirements for the healthcare agent. Just very briefly, they need to be 18 years of age and older. For those of you who have 18-year-olds in your life, you might think it would probably be best if they were a little older. That's quite young to make medical decisions for somebody, but that is the legal requirement. The person you name on the document cannot be your physician. So we often get that question with patients. And I heard a physician say it really beautifully. We have patients say, well, why can't I name my doctor? My doctor knows me best. And in response to that, I heard a doctor say recently, well, I may know your medical history best, but I don't know you best. I don't know what's really important to you, what religious experiences you have had, what your past experiences have that you've had, what you really value. So a lot of documents say that that who you name on the document cannot be your physician employee, but of course there are exceptions to that if that person is related to you by blood or marriage. The person you name can also not be your administrator, owner, or employee of a facility where you receive care. And again, there can be some exceptions to that if that person is family. So qualities of a good healthcare agent. These are really good things to think about. We'll talk with people who will say, well, I have 5 kids. How do I choose which one would be the primary decision maker? So things to keep in mind is, first of all, should be somebody who's willing to have this conversation with you. So if somebody says, well, I have 2 sons, but they're not really willing to talk about it, then we start the conversation of, are there other people in your life that you trust? Or how can we help with that conversation with your sons so they are more comfortable with it? So it absolutely should be somebody willing to have the conversation about your values and wishes and what's important to you. Somebody who's willing to follow your wishes, even if they don't agree with them, or if they have a different idea of what they would want for themselves. So the person who you choose does not need to be 100% in agreement with the decisions you're making, but they must be willing to follow your wishes and willing to ask questions for more understanding. I'd say one of the most important things is choosing somebody who's able to make decisions in stressful and emotionally challenging times. So this is something important to consider when a lot of people may automatically choose their spouse, but it's important to consider how that might feel and whether that person really has the capability of making medical decisions for somebody that they're so emotionally connected to. So really important, again, if you do have 5 children and you sit them at the table and you say, these are my medical wishes, these are what I want you to do on my behalf. I sometimes joke and say, you might see a few people kind of backing away from the table. So it's good to just engage in these conversations and see what comes up. Lastly, the person has to agree to be your healthcare agent. So if you're naming somebody on a legal document, they want to know that their name is on there, and they also want to agree to be able to be your medical decision maker when needed. So what happens if you don't choose a healthcare agent? So I think we have this question come up a lot. I get this is a good idea, but do I really have to do this? Why is it so important? Wouldn't it automatically be my spouse anyway? So what we're going to talk with you about is in Washington State, in all states, but what we have an example here is in Washington State, there is a medical decision hierarchy. So if you ended up in a healthcare system, we have to talk to somebody. So the first thing that we're going to look for is, does this person have a guardian appointed by the state? So that's a rare situation, and you would know if you had a guardian appointed by the state. If you do have a guardian appointed by the state, they're the #1 decision maker. The next thing that we're looking for is a durable power of attorney for healthcare document. A document that is a legal document that you have acknowledged and appointed somebody to be your medical decision maker. If we don't find that document, or you have not completed that document, then we have to go to the legal order of decision making. So you can see this here. I won't go through the whole list, but just to say that the first person that we would go to is your spouse or registered domestic partner. So it's important to recognize that that is who we would speak to if you haven't chosen a healthcare agent. And in some situations, that may be who you would have chosen anyway. But some things to consider is that one of the challenges and the beauty of being in relationship for a long time is that we grow old together. So sometimes we'll see partners where they haven't completed this document, people who are married, and one of the spouses has early stages of a cognitive decline, for example. That person is not maybe the best person to make medical decisions, but they had not taken the time to choose somebody else. So the first person we will talk to is the spouse. If you do not have a spouse or registered domestic partner, next in line for decision making will be your adult children. And adult children, again, are anyone 18 years of age and older. And you'll see that small asterisk in the box, and this is where things start to get complicated. If you have more than one person in any section here, so if you have more than one adult child over the age of 18, then in Washington state law, we have to consult with all of your children, and they have to all agree on the type of medical care you do or do not get before we can move forward. So again, this is the hierarchy for Washington, and that all have to agree is true for Washington state. That's different in different states, but it's really important. We have to bring everyone to the table who's in a certain section. If you don't have any adult children, then the medical decision making would go to your parents. And again, if you have more than one parent, even if they've been divorced for some time, we by law have to do due diligence to reach both parents, and then both parents have to agree on medical decisions. And you can see as you're going down the list, the next is your adult siblings. If you don't have anyone above that, it can go to your adult grandchildren. So this list has extended recently to open up the opportunity for people who do know the patient to speak on their behalf, but you can imagine it can get quite complicated with multiple children, multiple siblings, multiple grandchildren. So once you have considered who you would choose to be your medical decision maker, and again, in all of the information coming out around COVID-19 and some of the information we're going to share with you very shortly, one thing that seems the common thread in everything is how important it is to choose your healthcare decision maker, and how important it is for that person to really understand what's important to you and what you value. So a lot of documents, you'll hear us say we encourage you, even if you already do have documents, to re-look at them, because a lot of documents will just have you name somebody and then what kind of care you would want in very specific medical scenarios, and that's the end of the document. So we have to hope and trust that you've had some valuable conversations with these people. Answering questions such as, what makes your life worth living? What level of engagement with others is important to you? And that could be engagement on a physical level or engagement on an emotional or mental level. What is your line in the sand? This is a way of framing this that I learned from Charmin that I love, that some people would say, I would be willing to receive medical care, go into the hospital, etc., unless I wasn't able to blank. So what is the line in the sand for you? Is it being in your own home? Is it being able to know who you are and who you are with? Is it being able to do your daily activities? And if we're talking about daily function or daily activities, are there certain activities that you do now that you cannot imagine living without? So it's important to dive deeper into these conversations. Another question that's been coming up, especially around the time of COVID, is what are you willing to go through in order to have more time? What are you willing to go through? What are you willing to have your family go through in order for more time? And if it's more time that you're looking for, what's the quality of that time look like? So you can see where the conversation needs to go deeper than just naming somebody and how you would want to be cared for in certain medical scenarios. So I love this example of a life statement. So sometimes people will choose to just have conversations with their families and continue to have those conversations. The Honoring Choices document that we use widely in Whatcom County and within Washington does have some of these questions incorporated into the document about what you value and what's important. But I'd love to share this life statement because sometimes people can just wrap it up in a really beautiful life statement that gives you a lot of information about who they are and what they value. This was a life statement that was in a book called Take Care of Dying and Get On With Living that was written by an incredible woman named Theo Wells. And I believe she wrote it when she was in her late 80s or 90. Charmin shaking her head. I had the opportunity to meet her. So she wrote, "To me, to be alive is to be able to read, write, speak out, learn, and care among others in my community. If I cannot do so, it is time to move on to a more fruitful continuance of soul growth. To me, that transition is death." So that really lets you know who this person is, what they really value, what the quality of living and engagement is important to them, and at what point would she want to transition to more comfort-focused care. So the healthcare directive, we've been talking about healthcare agent, choosing a medical decision maker, what's important to communicate to them. The healthcare directive part of the document or the living will or directive to physician is limited. It is regulated by legislature what can be in a healthcare directive. So there are only 2 scenarios covered in advanced directives. So it's important, first of all, for us to understand what is life-sustaining treatment when we're saying, yes, we want life-sustaining treatment or not. So I'm just going to read a brief definition of life-sustaining treatment on the Honoring Choices document, which I think is really helpful. So life-sustaining treatment or life support can keep you alive by maintaining or replacing important bodily functions like breathing using a machine. Some examples of life-sustaining treatment are cardiopulmonary resuscitation, such as CPR, breathing machines, feeding tubes, kidney dialysis. I will say in some situations, certain medications and antibiotics are considered life-sustaining treatments. Life-sustaining treatments can be used temporarily until the body can function on its own. In other situations, life-sustaining treatment can prolong the dying process without the possibility of cure. Easing pain and providing comfort are part of routine care and are not considered life-sustaining treatment. So you can see at the bottom of this slide that comfort care will always be provided. That is a concern for a lot of people. If they say, I don't want life-sustaining treatment, will my pain still be treated? Will my dignity still be attended to? Will I still be cared for? So absolutely, life-sustaining treatment is a more high level of care that is prolonging the dying process potentially. So most healthcare directives, again, I've been saying they cover 2 scenarios. Most healthcare directives in Washington state and most states cover a terminal diagnosis. So if you were already at end of life and there was no chance of cure or change, and you were unable to speak for yourself, what kind of care would you want? Or if you were in a persistent vegetative state or a coma, would you want to continue life-sustaining treatment or would you want to discontinue life-sustaining treatment? So as you can see here, the challenge is that less than 5% of people have these two very specific scenarios when they become unable to make their own medical decisions. So it's very important. The conversation is really important, and getting more detailed is very important. So I've been saying that there are some tools out there to help guide these conversations. This is one that we've been using quite widely in Washington State, at least within Peace Health. It's from the Conversation Project, and that will be on your resource list. And it's a really beautiful, easily followed guide. 3 things that you can do now. So again, thinking about how out of control many things that are happening right now are for us, and really how this conversation and engaging in this work can help us feel more in control. So you can see there, picking the person who will be your healthcare decision maker is number 1. Talk about what matters most to you is number 2. And think about what you would want if you became seriously ill with COVID. And it has all these questions that you can answer and then share with your family. So I strongly encourage you to check out this guide and use it to help engage more deeply in this conversation. So we've talked a little bit about how the healthcare directive part of the advanced directive can be limited. And there are addendums that people have started to add to their advanced directives. There are some addendums coming out for COVID-19. One of the resources that you will get is a resource for the Peace Health Advanced Care Planning website. We do have an example of one of those addendums that is very specific to the diagnosis of COVID. There are addendums for dementia. So it's very important to understand that even though dementia is a terminal diagnosis, the way that most documents are worded is a terminal diagnosis where somebody would likely die within a short period of time. And if you know anyone who has lived with dementia, you know that it can last for a long period of time. And with dementia, it can be a long period of time where somebody needs to make medical decisions on your behalf. So we'll be giving you some of those resources in the resource page for addendums for a diagnosis of dementia. There are also mental health directives or addendums around mental health. So there are specific scenarios for people who are living with mental illness and may want to say specifically how they would want to be cared for if they had more of a medical emergency related to that mental illness. And I'm going to turn the conversation over to Sharman. Thank you.
Thank you, Hillary.
Yes.
Yes, thank you, Hillary. That was a great lead in, and I just really appreciate how thorough you are as you cover the basics around advanced care planning and helping us kind of get started into what it means to really be talking about our goals and values. We did focus this talk on how proactive planning looks in this setting of a pandemic, of an illness out there that we know doesn't have a good cure, and that is really producing the reports that we're hearing in so many sources are giving us reason to really think about how we would want care. I think what do we know about COVID-19 that might influence these choices that we make? And how is it different from if we think about whether we had a stroke or whether we were in an accident? So obviously one of the main features about COVID-19 that we're all very aware of is that there is no treatment, no cure, no vaccine to protect us from it. And that it's so easily transmittable, not unlike a common cold would be, but certainly with more devastating impacts in some people. We hear about the reported low survival rates. I think it's good to keep in mind, and I actually spent quite a bit of time the last couple of days looking at that data that I'd found 3 weeks ago and realizing most of the data that was reported even up through the end of April, that data is already changing because so many of the cohorts in those studies, one study out of New York had 5,200 people in it, but only half of them were included in the early data because the other half were still sick, and they weren't going to know how that was going to turn out. So our survival rates, even our data is changing. I'll be very anxious to hear when that the rest of those New York cohort is reported, and when we have a final study. There were some scary, like 80% fatalities and even 97% in some age groups. And I think we're going to see those numbers shift downward to maybe 50%. So it's good to not be too caught up in the fear and in what you read. I talk a lot with friends about this, and we talk about sort of doing, taking vacations from checking the news and letting ourselves just get a break from that. Other things that we know are true about COVID because of the exposure risk is this very limited and often no visitors. If you were to accept going to the hospital, certainly if you're in the ICU, it's really challenging our healthcare providers to figure out ways to use technology and telehealth and iPads and whatnot in the ICU rooms so that families can talk to their loved ones. I read an article recently of how nursing care has changed. So one of the newer treatments or treatment protocols that seems to be helpful is keeping people face down. And that somehow the lungs work a little better in that position. But the nurses are stating that now when they walk in a room, they're not even connecting with that person's eyes or their face. So they're having to sort of adjust their care to get that personal connection so they can care for folks. Another thing that we know is that when people get sick, most transmission is happening within people's homes. That means not only will you be sick, but potentially other family members will be sick, maybe before you, maybe after you, but it may really affect their ability to be an advocate for you if you've chosen them as your healthcare agent, or if they would naturally be that person according to that, that hierarchy that Hillary showed you a moment ago. So this is where it becomes more and more important to figure out who are those people not only living with you and close to you who could speak on your behalf, but maybe choosing someone who's in a different community or lives in a different household. Who are those alternate agents that you could name? We have a couple more slides. So Hillary, let's go to the next one. So what are some specific things that you want to consider as you're looking at doing this process of looking at what's important to you? One thing we know is that it's more important than ever to talk about what you want. Once people become ill with COVID-19, it can move fairly quickly from realizing, oh, I have some symptoms that are troubling me, to being very sick and not being able to talk about what you want. So I'm going to take just a minute here. These conversations, and I think that's happening naturally. We're seeing and reading so much about what is out there, and I think our families are thinking about it more. But I also know that a number of people feel somewhat protected from it. And so if you've got people that are important to you, that you especially that you know you're a decision maker for, you want to make sure that you really understand how important they are. And again, important to review those existing documents, make sure that they're easy to follow if you get COVID-19, if they are only pertaining to those terminal illness conditions and permanent coma or vegetative state that Hillary mentioned. You may want to add statements to those, whether it's an addendum or just changing the document. Also, this involves looking at who you have named as your agent. If you have considered other backup people, make sure that your power of attorney, and usually they have room for a primary person and then a first and a second but you can list a third and a fourth. Realize that the legal power of attorney status can only go to one person at a time. Some people say, oh, I want all three of my kids to decide together. And that can be an informal agreement and something that you state as a wish of yours, but legally you have to list them in an order and make sure that everyone that you wanted included as a backup person is on that power of attorney documentation. Then look at how your wishes are expressed, as I was talking about, and make sure that they will cover your directives. For many people, they will. If you have a values-based directive and you say, I would be willing to go through a short amount of time, say a few days on a ventilator to recover from pneumonia, or I would be willing to go through surgery, you know, you've kind of named what your line in the sand is, as Hillary said. That might cover your wishes very well. Talk it over with your healthcare agents and with the people who are going to be contacted and make sure that they would understand how to make decisions. What we know, and I'm going to get into that in a future slide, but I'll just say, if they don't seem to cover the kind of situations that you feel they need to, then that's where you may need an addendum. I don't think an addendum is required. I think sometimes it can complicate, but if you're someone who really likes to be able to express very accurate, very detailed plans about how you want to be cared for, take a look at the addendums that are out there and see if that would help you feel that your wishes can be more fully honored. Basically, an advance directive can and should contain anything that you as the individual feel is needed so that we as the healthcare team and your agents can give you the best care that matches with your goals and your values. Next slide. So we're going to transition now and talk a little bit about the POLST. I'm using the name Portable Medical Orders. We are actually in the process of revising this, and this is our new proposed title. It's previously known as Physician Orders for Life-Sustaining Treatment, but it's not just physicians that sign this order. It's anyone who has that license to be a primary care provider for you. So it could be a nurse practitioner. It also could be a physician's assistant, who may work in concert with other medical doctors in a practice, or maybe the only person that you see. So what it is a set of signed medical orders that is, so we call this actionable and portable. So it moves with you, it stays with you, it translates whatever you might have expressed as your wishes for care and how you want to be cared for into medical orders. This set of orders is really designed, it was built and designed to be actionable in an emergency. It's actually not a great order set. This is not the order set that the doctors will use when you're in the hospital ongoingly. However, it may guide those initial moments of caring for you and knowing what and what not to do as you enter a hospital. But the really big benefit is that the emergency responders, EMTs, our whole EMS system, this is a document that actually was created by their statutes so that they have a set of orders in the home. And we'll talk a little bit more about how this differs from an advance directive in that way in a little bit. Go ahead, next slide. So when, I talked just a minute about when Pulse becomes active is in the moment that you have a need. And that's where it is different from an advance directive, which tells people when I get sick, if I need future care, at some future date, it's going to direct my care. The Pulse is active in this moment that you actually are having an emergency. The emergency responders, as I said earlier, they have to have a set of signed medical orders. So this lives to, again, translate those wishes you have. What's so important to understand is that you have the piece of information about you, who you are, how you live, what's important to you, your healthcare provider, your doctor, your nurse practitioner, PA, has the information about the kind of medical condition you have and whether or not certain kinds of care would benefit you. The bringing together of those two bodies of knowledge becomes this shared decision making, where your doctor is able to help you decide, based on your medical condition, would getting care in an emergency in your home benefit you or not? In other words, by benefit, I mean, is it going to end up with an outcome with you being able to live a life that you would consider meaningful? So let's go to the next slide. So that's why we want this to be active in your home. We want it to represent what you want wherever you may be living. And is not designed to be used in the hospital. In the hospital, doctors can write different orders every hour depending on your condition to and change as you improve or not. I've certainly seen in my work in the hospital where someone might be on a ventilator one day and be full code, and we're going to do resuscitation, and then on the next day they're still on the ventilator, but we've decided not to resuscitate them if their heart were to stop. And then maybe 3 days later, they've improved a lot and they're back to, yes, we're going to resuscitate them, and now we can take them off the ventilator. So that's how fluid things can be in the hospital. The pulse is more cut and dried, because those emergency responders need to know what to do and what not to do. And I would say, here's where we want to make sure that we're not trying to ask for a little of this and a little of that. Basically, the emergency care team needs to be a kind of all or nothing medical care, especially in the case where they found someone who actually is in the dying process. So I'll come back to this issue about it being active in your home or in a residence. So that residence might be a long-term care facility or assisted living or some other kind of group or adult family home. And I'll talk a little bit about that in a minute. And then people ask a lot of time, well, it's fine if the wear is in my home and my emergency happens at home, but what if I'm, at Fred Meyer or out with my daughter for lunch? So keeping a copy with you means that those emergency responders would have guidance wherever you are. But it's important to realize that we live in a society where lots of people are clued in now to how to provide life-saving care. Washington State has one of the highest rates of CPR-trained bystander CPR courses and certified people who can do basic CPR. We also have a preponderance of these automatic defibrillator devices on ferries and in malls and lots of public places. So this form isn't a guarantee that you won't have life-saving care given to you by bystanders. And of course, someone has to know that you have it with you so that they can show it to the EMS if they do arrive. So next slide. So just overarchingly, I've referred to this a couple of times. Why would you want to have a pulse? So if you are living with a medical condition or just because of how you want to live your life, are absolutely sure that you would not want to have any kind of emergency, including one in which you might be dying, responded to, and you want emergency responders to have orders so that they can honor that, just know that they cannot act on a legal directive. Having advanced care plans that state you wouldn't want CPR is going to leave them conflicted. Now, sometimes they can call medical control, they can read the document or send it in, but realize all the time that would take, and when they're looking at seconds to try to decide whether or not you would want life-saving measures. So this allows them to act very quickly in terms of honoring your wishes, and really gives them, if the decision on the post form matches with the person. And I think of a lot of elders that live, their quality of life is such that they're not living independently. They're living in assisted livings, or they're living in long-term care, and their quality of life is declining. We know that this is where the conversation with the medical provider is so important. That person who knows their medical condition best is the one that needs to be talking with them about their chances of surviving an event like that, or their chances of coming out, even if they were to survive an event like that, and having normal function, or a function that they would consider reasonable and meaningful, might be quite low. There's documents that are available in some of our CPR guides that show that the survival rates of someone living in a nursing home when we do CPR to them is about 1.7%. And that's meaning that at the end of a month, they're still alive. The rate of neurological decline, or having their behavior and their +ability to think and act and live the way they want, is also, even for those few that survive, 90+% of people don't return to the kind of function they had before. So just knowing where you stand in that sort of range of outcomes is really important. So bottom line is, if you think you want to post, it's talking with your doctor and having a really frank discussion about your own medical condition and your values, that out of those two sets of knowledge bases, this decision can be made about whether you want to post. The other thing I have on this slide is your loved ones need to know that you've made a decision. So at the time of an emergency, everyone is going to be really emotionally flooded and not able to make good decisions if they are clear. I mean, our knee jerk is, do everything, please save mom, save dad. It's just so ingrained in us to want to go for life, and that's not a bad thing. It's a great thing about us as human beings. But if you've been very clear that that's not the kind of outcome that you want to have, that you don't want, that your outcomes will not be good, that you're not willing to accept that, you'd really rather to be allowed to die a natural death in the moment, and that's right for you and your doctor agrees, you need to make sure that anyone who might be in that home, in that setting with you, whether they are a named healthcare decision maker or not, they need to know how you feel. If it's your care, the person who comes 2 times a week to fix meals for you, or if it's the person that your neighbor that you go out for lunch with, or your bridge group that you meet with weekly, decide who are the important people that you spend time with, who might be there in an emergency, who also need to know your condition. We took care of both of my husband's parents at home, and after his dad died, it was another 10 years that his mom was at home in her 90s. She had so many care providers that loved her and enjoyed her, and we were so lucky to have a great team. But when we knew that we really didn't want, she didn't want to be resuscitated. She loved her pulse form. She had like 5 copies. She kept one in her golf bag because she was still golfing during part of that time when she was 94. But we had one care provider who could not live with the fact of not starting CPR. So we changed her to be the person that just made meals and delivered them and didn't do in-home care. So that's kind of a good example of that. Let's go to the next slide. I want to make sure we've got plenty of time. This is a kind of an amended version of something that I use when I'm training doctors to have these conversations with any of you. And I've hoped I've made the wording in here a little more simple. There's a lot of words here and I apologize, but the main idea here is that your value and your goal for your life actually matches up with the kind of care and where we would care for you. So if we look at where you end up, what your location of care would be, if you say to us, I am willing to go through pretty much anything, at least initially, at the chance of having more life, so we would call that a goal of longevity, that means we're going to be willing to give you, not only get you to the hospital, but do all those aggressive, intensive care type treatments. It'll mean tubes, breathing machines, kidney machines, all of those life-sustaining treatments that Hillary outlined so well. It's the kind of the full meal deal. Now, realize that doesn't necessarily mean that you have to be saying yes to CPR, because sometimes people get very sick, but they still have a heartbeat, they still have breathing, and they can say, yes, keep me alive as long as I am alive, with as much care as you can provide to keep me alive. And still say, but if I die, I'm going to draw the line. Don't try to restart my heart. Don't try to bring me back. So realize that it's possible for your pulse form to say full treatment in the section that indicates the kind of treatment you want, including ICU, but it might also say do not resuscitate, which is important to realize. Another kind of goal is I would be willing to go through things that might return me to health, but if I'm so sick that I'm not likely to come out of it with the kind of meaningful life that I've talked about, and my doctor says with my heart disease or my whatever, that I'm probably not going to survive or do very well with aggressive treatments, I'm going to choose that independence, that middle. I would want to go to the hospital if I had an antibiotic. I might even go through a surgery, but I don't want to end up on machines. And then the third group of people are really, and often these people who choose quality of life maybe they've got a chronic illness or a known serious illness, and they've been through hospitalizations and they've kind of experienced often the limitations of how their quality of life may be declining, and they really want to stay home as much as possible to get as much time with their family as they want. This is certainly a time to be considering palliative care. Some folks, at some point, everyone will qualify for hospice, usually. I shouldn't say everyone, but if you're in contact with your providers and letting them know that you would love the support of palliative care or hospice, that can be considered during this time. People who choose the independence or the quality of life are those two choices are going to go along with also not choosing to have the dying process reversed. They're going to be DNR, do not attempt resuscitation, by and large. And there are some exceptions, but that's important to keep in mind. Next slide. So just some takeaways. It is this shared decision-making, and I think you can, as Hillary mentioned earlier, this is a great conversation to bring up with your doctor, especially if you're someone who maybe doesn't fit that camp of being very declined. Maybe you are still living independently, but you just want to know if this is going to fit for you. Realize not everyone needs a pulse. Everyone needs an advance directive. But in emergency situations, most people will want and should get full emergency efforts to sustain life or even to revive them if they're dying. And then in the hospital, your values expressed in an advance directive can tell us how much of this do we do and how long do we do it. Understand that what it means to say that you're going to limit emergency care. You want to be really cautious, aware that if you were to have that pulse that says DNR, it means if you were to suddenly be electrocuted and your heart stopped temporarily, and it could be easily restarted, that those efforts might not be available. So just be willing to have a really in-depth conversation with your provider about what it means to choose to limit emergency care. It's very important if you do or are going into assisted living or adult family homes, if you are the advocate for someone who's living in those settings, ask them what their policies are around POST. There are provisions in Washington State for residential care settings to have their care providers trained to honor POST. Many are not accessing that, and they're just kind of out of ease making a blanket statement that everyone gets CPR. So just know that, and if you need any help, if we can help in any way, giving information to those caregivers or to that organization that you are being cared for in, or you have someone who's being cared for in those settings, we might be able to help you. We have in the past been able to help them realize that they can give their caregivers the training to actually honor a POST. And carrying a copy with you is always a great idea. Taking a picture on your phone is valid. Digital images are valid. Next slide, Hillary. Oh yeah, and this is where I turn it back over to Hillary. So we'll have plenty of time for questions if there are any questions as a result of all that.
Thank you so much, Sharman. So I just wanted to sum up a lot of the things that we have been talking about in sort of a next steps checklist for those of you who either have not completed any of these documents in the past or want to review your documents and maybe redo them. So as we've said, decide who will be your healthcare agent or your healthcare decision maker and have a conversation with them about your wishes. And keeping the conversation going with changing times, as we've been talking about throughout this webinar. I would also say that super helpful to have these conversations about your care with anyone in your family and anyone who might show up at your bedside in order to avoid any conflict, as Sharman pointed out when she was talking. Complete an advance directive form, which will include some sort of durable power of attorney for healthcare and healthcare directive. Add addendums when needed, and again, we'll send you some of those resources. Sign the document. In Washington State, you can sign the document in front of either 2 witnesses or a notary. We do often recommend that if you travel, it's really helpful to have the document notarized because some states do require notary and it may just be seen as a more valid document. And then have a discussion with your healthcare provider. Most insurance companies, definitely including Medicare, will cover, will allow advanced care planning visits to be reimbursable. So your provider may not bring it up, but I encourage you to bring it up to share your documents with your provider and then also have a conversation with them about if it would be helpful for you to have a POST. So making copies of the advance directive, always keep the original of the document. You want to make sure that you give copies to your healthcare decision makers, whoever you've named on the document, that your primary care provider has a copy. And again, I encourage you to schedule an appointment to talk with them about your document. Now's a great time to do that. They're very aware this is on the forefront of many people's minds. And then get a copy on file at your local hospital. Really, really useful to have it on file at the hospital so that it's easily accessible if you have a sudden or unexpected medical emergency. If your local hospital is Peace Health Hospital, there's information here on how to get it on file, either by mailing it in, faxing it in, or emailing it. If you have a Peace Health provider, you can also just carry it into the clinic and ask them to scan it into your medical record. Another reason to have it on file at your local hospital is that if you had an emergency situation out of town, out of state, quite often what hospitals will do is call the hospital closest to the home address on your driver's license to say, we have Hillary Walker here in the emergency room. Do you have an advance directive that could help guide her care? And then that hospital can fax your document to them to help guide care. This is just information you can call medical records again at Peace Health to see if your document is on file there. So we came up with an easy way to think about when to relook at these documents with the 6 Ds. So those of us in the advanced care planning world, this helps us remember how to remind folks. So at least every decade, I recommend looking at them more often, but at least every decade. If you go through a divorce, be aware that if you did name your spouse as your medical decision maker and they are still named on that document, they are still your medical decision maker. So if you would not want them to be your decision maker after a divorce, you need to re-look at your document and potentially redo it. If you have a new diagnosis, you want to look at the document and see, is it clear enough specific to this diagnosis, or have my values and my wishes changed? If you have a decline in your health, either you or who you have named as your medical decision maker. So again, as we spoke to earlier, if your spouse is your named agent when you were younger and then they have their own chronic illness, you may want to consider naming somebody else as your medical decision maker. The 5th D is death, and that is if who you've named on the document has died, you want to be aware that if they were your primary medical decision maker, who you named as your alternate is now your primary person. So if anyone who you've named on the document has died, I recommend re-looking at the document. And then distance is just if you move to another state, really helpful to understand what the laws are in that state around end-of-life care and medical decision-making, and look to see what documents are being used in that state or county where you are. If you have an advance directive, let's just say for Washington State, not a bad idea to travel with it as part of your travel documents so that, again, it's easily accessible. Your document will be used to guide care in other states. Whether it can be followed word for word will depend on the state where you are and the facility where you're receiving care. But to be aware that one thing that your healthcare decision maker does have a right to do is request transfer to a facility that can best follow your advance directive. So not a bad idea to carry it with you, especially that power of attorney for healthcare piece. So we want to thank you so much for sitting through all of that information and for being here today and considering all of these questions. And now we're open to your questions.
So thank you, Hillary, and thank you, Sharman, so much. Very, very informative. As people are thinking about what questions they might want to ask in either the chat function or the Q&A function, one thing in that list of the Ds, when I think about death, I not only think about the person who might be my healthcare agent dying or a decision maker dying, but sometimes if I have had a person close to me die, it makes me reevaluate my own choices. You know, what I witness in their dying might change my own mind about what I'm willing to do or what I'm not willing to do. So if you can just add that sort of larger question about death. So we do have a question. Hang on, let me get to the Q&A here. So one person asks, do you get the advance directive or POLST notarized? And if so, how do you get them notarized?
So the advance directive does require either 2 witnesses or a notary. So that's the medical advance directive, that's the legal document. And now in this time, it's a little more challenging to get notaries and witnesses, but most banks are taking appointments to still notarize documents. And many clinics do have notaries still available. So those are some things to consider. I've heard lots of creative ways neighbors are witnessing documents for each other, waving and signing them, putting them in mailboxes. And so you do need to get creative. The POLST form does not require witness or notary. It does require your provider's signature. That is a medical order. So just like any other prescription, it requires the signature of the provider and the signature of the patient or that patient's medical decision maker.
So I'm going to stay on the idea of notary.
Okay. Yes.
So another person says, I have a notarized advance directive, but I did not name my alternative on it. Now I have, do I need to get it re-notarized every time I make a change?
Technically, yes. Yeah, one of the challenges is that the advance directive documents now are mostly in paper. They're not in digital form. So it does make it more challenging to make changes or additions to the document. So yes, if you make a change to your document, you need to redo a new document and then make sure that new document is on file wherever those documents are. And if we have a new file, a new document on file at the hospital, we always go by the one with the most recent date.
Anything you want to add about notary, Sharman?
Yeah, no, I think that's correct. I mean, you know, if your document has space for it and you're adding it in, the problem with that is that if you filed it anywhere, they're not going to have the most recent ones. Whether you have someone initial it or you add witnesses to it instead of the notary, I think you could do either one. I noticed too that in someone asking about how getting them notarized, realize that the POLST does not need to be notarized because it is actually not a legal advance directive document. It is a medical order. So what verifies a POLST is the fact that it will require, and there's spaces on the front for both your signature and the provider's signature, and that makes it legal. We're also seeing that in this time of COVID, where people are doing more telehealth visits, it might be that a nurse in a nursing home with a patient, that the doctor is actually talking to the decision maker who's the daughter in Arizona. And so the nurse is going to be documenting that the doctor gave a telephone order and that the daughter in Arizona gave a verbal consent. So there may not be any actual signatures on the POLST form, except the nurse's notation, hopefully two nurses noting that, that they are confirming that the doctor both gave the order or the nurse practitioner gave the order and that the appropriate surrogate gave their consent for the orders. So there, we are being a little creative about how those are being verified in this time.
So another question, more COVID specific, is that with bad cases of COVID, and particularly for those of us in a high risk age group or with a high risk diagnosis, we're really concerned about going on a ventilator since recovery numbers seem to be so low.
Yeah.
Is there things that we should be saying about that in our directive, or what kind of conversation should we be having with our agent about that?
Yeah, that's a really great question. And that's where, when we kind of talked about these addendums, again, you need to look at how you've expressed your wishes in your advance directive currently. And you probably, or you may feel that it isn't adequate. Have you said, how long would you be willing to go on a ventilator? Some of the things that we mentioned in the talk are realizing that if you say yes to a ventilator with COVID and you're really willing to like, give me whatever you can that with the chance that I might survive this, knowing that some people are surviving it. Like I said, those numbers actually are probably not as dire as we at first thought, because our treatments are improving. Then you need to realize that it's going to be a commitment of weeks, potentially even a month or more on that ventilator, during which time very little visiting is going to be allowed. You're going to be sedated most of the time. And then there's all that effect out down the road of having been so just not moving our bodies. Our bodies don't like that. So that's where that really good conversation with your care provider. Is this really something that I should be worried about? Hillary mentioned some of these tools. Hillary and I are doing, and I statewide am doing lots of training for doctors, helping them talk specifically to each person about how COVID is going to affect them and what those decisions specifically would be. So if you feel your directive doesn't say enough about what is needed, take a look at the addendums, but just have those conversations with your families. I think that's a great question, and reach out to us and get help with that if you need. A good question about the witnesses. Yes, they're actually different.
Read the question, Sharman, so everyone can hear.
If we choose not to do a notary to notarize the advance directive, which is the power of attorney and the healthcare directive, there are different requirements for the witnesses on those two documents. So if you have a combined document, you sort of have to go with the most restrictive. And we will send a resource. We didn't actually cover it because it is a little bit of jargony and detailed. But just to answer, yes, people have to be over the age of 18, and they have to be certain types of people. For example, someone witnessing your power of attorney can't be anybody who could benefit from your estate, whereas those people could be witnesses on your healthcare directive. I think I have that right, Hillary. I hope it's not opposite of that.
Yeah.
People who are your adult family home providers, in-home providers could witness, or even your doctor's employees could potentially witness if they don't have a policy against it, your power of attorney, but those same people cannot witness your healthcare directive. So just it's a great question, and the answer would really take diving into what those two different lists look like.
So for you participants, are there any other questions? I think we've answered all the ones that have shown up so far. I'll give you another minute or two.
I know early on in the talk, one of our in-home care providers who was on the talk offered, Hillary had a slide that mentioned that the people that oh, actually you did have a slide about the witnesses, but also it's not only organizers and administrators and employees of a setting that you might live in, but also in-home home care agents. Often people get very attached to their home care agent or, person that comes to help them and wants them to be their power of attorney or be a witness, and they're not necessarily able to do that.
Right. So I do not see any other questions showing up. So I want to again thank Hillary and Charmin for giving us their wisdom and their insight today. I think it's a time when we're all thinking a little bit more about what it might mean to be seriously ill and the kinds of decisions we want to make. So thank you so much. And we will end the seminar. So thank you all.
Feel free to reach out to us if there are any other thoughts after as you think about this and talk about it with your families.
Yes, so a reminder that you will all get a resource list. And I will be sending it out when we get the link to this video as well. And Horacio or Devyani, I don't know if you have any last thoughts you'd like to share.
I'd just like to thank both of you. I think you've covered some really important ground out here. And some of it is just new information. So thank you so much for being here today.
Thank you.
Yes, and me too. Thank you so much for being here, and special thanks to Hillary and Sharman, of course, Marie and Devyani for all you've done to organize this wonderful webinar. Thank you so much.
Okay, thank you.
Thank you for having us.
For hosting us, yes, very much. Thank you.